or we have other etiologies like natural issue of the pre-eclampsia may just precipitate the pre-eclampsia. So those are the different elements that can precipitate, and you need to investigate on that. If it is ischemia, you can investigate on the ischemia of the patient, probably depending on which investigation it is. If it is infarction, you can investigate on that. If it is infection, you can investigate on that. Generally, the most common etiology of stress which is medically related are these two: infection and iatrogenic, which is related onto the past history and the infection. We have also infarction, which is trauma. Trauma is also very related, and we have ischemia. So those are the four major ones: infections, infarction, and ischemia. They are the three major causes of precipitating factors of stress related to medicine. So for infection, you can investigate for malaria in the patient. So to just know that the patient has an infectious process, just ask a full blood count, and you need to ask for the full blood count. You ask for a CRP, CRP. Now to confirm, because sometimes the full blood count may be normal, to confirm that there's an infectious process, you need to evaluate for the blood smear, where you're going to have a left shift. Blood smear, you're going to visualize the left shift of the neutrophils and all that. But you can just ask for the full blood count, the CRP, to visualize for infection. Now to know the cause of infection, you can ask now for malaria parasite. Other elements for infection, you can do the blood culture, to visualize if there's any infection in a patient. So those are the elements of how you need to evaluate for the complication, for the precipitating factors of the hypertension in the pre-eclampsia, which can result to all those signs and symptoms. So after evaluating for the precipitating factors, we need to evaluate now for the complications. So you need to now see, we are going to start with the complication related to obstetrics, the obstetric complication. So the first thing is, we can have the fetal complication and acute fetal distress. When you want to evaluate for acute fetal distress, you do obstetrics ultrasound. And the particular obstetric ultrasound that you do to evaluate acute fetal distress, you do obstetric ultrasound with biophysical profile. And when you are doing the biophysical profile, you evaluate for the Manning score. You evaluate for the Manning score. And now in evaluating the Manning score, there are 5 elements. The first element is the fetal heart rate. It can be a stress test, by using the stress test. The second element is by after evaluating fetal heart rate, you evaluate for respiration. For the respiratory movements. Normally it has to be between 12 to 20 cycles per minute. The third, after evaluating for respiratory movement, you evaluate for a fetal tone. The fourth, you evaluate for fetal movement, and then the fifth, you evaluate for the amniotic fluid volume and the tone. Now for the amniotic fluid volume and the tone, so those are the different elements. All of these elements is 2/2, so it makes the total of 10. When you are assessing the Manning score, a good Manning score, mild respiratory distress. There is no respiratory distress when you have 8 to 10. There is mild respiratory distress when you have 6 to 8. There is moderate respiratory distress when you have 4 and 5, and there is severe respiratory distress when it's 0, 1, 2, 3. So it's just like the Serum and Anderson score elements. So those are the different elements that you need to visualize when you are assessing the patients that has that in obstetric or with obstetric ultrasound. The next complication is the intrauterine growth demise. So to evaluate for intrauterine growth demise, you still ask for obstetric ultrasound. For obstetric ultrasound, your obstetric ultrasound now in this case, instead try to evaluate in obstetric ultrasound, try to evaluate for the fetal geometry. In this fetal geometry, you're going to measure now the femoral, you measure the biparietal diameter, you measure abdominal circumference, and all that can help you to estimate the fetal weight, which tells you if the patient is small for gestational age or you have a patient who is large for gestational age. Generally, if you have a child who is small for gestational age and is intrauterine, it's called an intrauterine fetal growth restriction. When you have a small for gestational age and the baby is intrauterine, it is intrauterine growth restriction. And what is now the definition of intrauterine growth restriction? When you have the weight of the child is less than the 10 percentile of the weight of all the children of the same gestational age. That is the definition of intrauterine growth restriction. The next element is intrauterine fetal demise. So when you do evaluate for intrauterine fetal demise, we now still have to do the obstetric ultrasound. And to do the obstetric ultrasound, here you're instead going to have one, you have the scalp edema. Is it clear? So scalp edema is one sign. The second sign, you have maceration. Is it clear? You have maceration of the skin of the fetus. The third element, you have the Romberg sign. Romberg sign is a thrombus which is located at the level of the heart of the fetus. Is it clear? So those are some signs that can tell you that there is signs which can tell you that there is acute intrauterine fetal demise. So those are the different elements. So after that, now you need to evaluate now for when you want to evaluate for postpartum hemorrhage. Is it clear? So for postpartum hemorrhage, you just need to evaluated clinically. Is it clear? So when you have a loss of more than 500 mils in a vaginal delivery, or you have a loss of more than 1000 mils in cesarean section, or a loss of any volume resulting to a hemodynamic instability is defined as postpartum hemorrhage, and that is visualized clinically. For placenta abruptio, you see as for obstetric ultrasound, we to visualize absent placenta abruptio, but you're going to have signs that I'm going to explain later. Then you're going to have also eclampsia. Eclampsia is clinical. To evaluate for hemolysis, you need to evaluate first for hemolysis, but for the HELLP syndrome, you need to evaluate for hemolysis, which can tell you that what in hemolysis you have you can see it from one. You can ask for the elements which can evaluate for hemolysis. What are the constituents of hemolysis? Is it clear? Hemolysis is made up of one, you have anemia. Is it clear? So you can assess for the full blood count to evaluate for the HB level. Is it clear? The second element of hemolysis, we have jaundice. Is it clear? So in jaundice, you have to assess for the bilirubin level, which can tell you that there is hemolysis. The next element, since in red blood cells you have the lactate dehydrogenase. Is it clear? The next element that you have to assess in hemolysis is the lactate dehydrogenase. So that's going to be increased in hemolysis. And the other one, you have the iron workup. Is it clear? So you have serum iron is going to be increased, the transferrin and all that are going to be increased in the case of hemolysis. So all those are the elements to evaluate that the patient is actually hemolyzing. Now for elevated liver enzyme, you ask for the acute inflammatory enzymes, the liver enzymes. Is it clear? So the liver enzyme, you have the aspartate aminotransferase, which is the ASAT. Is it clear? You have the alanine aminotransferase, which is the ALAT. Is it clear? ALAT, and you have the alkaline phosphatase. Is it clear? So those are the three major elements that you have to evaluate. And then for low platelets, you evaluate it on the full blood count. Now to evaluate for the prognosis of the patient, generally you evaluate with the uric acid level. To evaluate for the prognosis of the patient, it shows you the severity of the pre-eclampsia and the fetal death rate if possible. Is it clear? So you evaluate now with the uric acid level. So all that can tell you the investigations that you're going to do in a patient that has pre-eclampsia. The next thing now is the management of the patient with pre-eclampsia.